So I'm thrilled to have the opportunity to present, and I'm very honored that they gave me the starting point. Mind you, they had to accommodate me because of some difficult travel plans, but it really is an honor to be here. And I'm going to, in my very short time, hopefully spend a bit of time explaining to you my visions on where my practice is going in implant dentistry. And the reality is, for all of us, every day is changing, and every day we critically look at what we have to do to create the best aesthetic and functional outcomes for our patients. And we're always pushing ourselves to present the best outcomes possible. And along the way, we struggle, we make mistakes, or we may not communicate well. And my goal is to, as I practice more and more, to do less of that poor communication. So I'm going to take you through a few of what I've referred to as my modules in my thought process of how do I get through to the end product that my patient wants in an implant reconstruction. I'm going to explore some of the critical areas, starting really with looking at bone. And bone, for me, it's the foundation for all of us. And if we get the bone right, a lot of things fall right with our implant treatment afterwards. And when I put this slide together, I really thought about, to me, bone is I've got to get those building blocks together, because we will all think about putting implants in a restoratively driven manner today, not where bone happens to be. Sure, sometimes we have to look at alternative methods, but we want to reconstruct as much as we can. So we look at the fact that there are many ways that we can augment a ridge. There's not really a right and wrong way, and I'll tell you, I have lots of different tools that I use in my practice. And there are some that I think are great little steps that I can consider, but I think we struggle still in many of the treatments that we do today. And it comes down to the fact, especially when you look at aesthetic zone treatment, we're challenged by the fact that the minute we remove a tooth, there's going to be some unfavorable bone changes. And most of our patients really don't have a lot of bone in this area. We have very thin facial bone plates. And the consequence is, even if I'm very conservative in my surgical protocol, these bone plates are going to change. So it reminds me that I extract one tooth, many teeth. I'm going to do everything I possibly can to maintain ridge architecture. For all of us today, we have to think about treatment planning before we treat, which means we're going to think about maintaining the ridge form in a situation where, for whatever reason, I can't place an implant immediately, or we may be looking at a fixed partial denture. And ridge preservation is such a valuable tool, but what we realize that even in ridge preservation, what we do today continues to change. In my history of what I've done, I have moved through the gamut of materials. I've moved from autogenous materials to biologics to more and more building in growth factors, whether they're autogenous or made by recombinant technologies, because we're looking for ways to make bone volume better. We're looking for ways to make bone quality better as well. But I also remind myself that I may choose to put a variety of materials underneath there, but along the way, we all have to kind of tweak things, right? Because we realize that the subtle little things we do right or the subtle little things we do wrong can actually very significantly impact the outcome at the end. So when I look at this is the same case. It was really realizing that one of my suturing techniques is actually appropriate in terms of what it does or does not do to tissue. So I've chosen to resuture in a correct way compared to how I started. Here, when I was using a figure-8 style suture, for instance, I was compressing the wound margin exactly where I really don't want to be. And in fact, when I think about what I'm doing, is I can do cumulatively a lot of right things along the way, but I can similarly do all the wrong things along the way to affect the aesthetic treatment outcome. My goal is maintain ridge architecture post-extraction. When I look at that photo on your right side, to me, that really shouldn't happen today, or we have to minimize it. We have to remind ourselves that ridge preservation procedures, whether it's one or multiple teeth that we're removing, our goal is to maintain the ridge architecture and minimize the changes that happen post-extraction. But the reality is that we rarely achieve perfect architecture, even with some of our more elegant or refined bone grafting techniques. But the goal through thinking about ridge preservation is we're trying to keep it simple from the moment of extraction where we have the opportunity so that we can avoid going on to more complex procedures. So you may think about more complex procedures as a variety of autogenous grafts where you're taking blocks from the ramus or the hip or the chin. We can also look at what can we do with biologics. So here, for instance, I'm reconstructing the ridge, and you can see the defect, which is going to be quite substantial in this individual smile line. We're using alternative materials, and with a variety of materials and a variety of approaches, we can do some really positive things in terms of where we bring the soft tissue levels to for our future restoration. But when I think about my own learning comes a lot from what I'm doing and focused on in the chair, but it comes from looking at my photographs after, because I look at this very critically. I thought at first, it looks pretty good, but when I'm more discriminating and I look at taking a line across there, shows me, well, where do I want my tissues? Well, I know already that with my plan here to place 2 implants, that the outcome is going to be compromised. We're going to have a stunted papilla. And historically, a lot of us would have always done 1 implant and a cantilever to avoid the side-by-side implant situation. Because even though I thought I did things right, I augmented it effectively to the level of the adjacent bone. I've used an implant which gave me good primary stability. I have excellent crustal bone stability. And yet, despite that, we see the aesthetic outcome is compromised. Really, the architecture is not perfect. In this patient's lip line, which is forgiving, it's fine, it's acceptable, but it's not really where I aimed for. I certainly tell you I sometimes have to accept compromises or limitations of the skills that I have or the ability I have to bring things to where they have to be, but I aim for higher or better treatment outcomes. But my literature tells me that in the inter-implant area, I'm destined for failure. Our tissues are rarely perfect. Sure, that's an average, and there's a huge standard deviation around that for how robust papilla can be, but you don't get those perfect cases where you have these lovely scalloped tissues in the inter-implant area routinely. Now, I put a little question mark, though, beside what I would always say was my gold standard in the past, and that was I tried to avoid side-by-side implants because of the papilla issue. And, we know that, or we think that we get more robust soft tissues where you have a pontic, or we can maybe make the tissues more robust by building augmentation procedures in there. But the reality is I put a question mark there because I'm not sure. The more I look at my cases, I'm not sure that my pontic sites have in fact produced better soft tissue levels for me. But I certainly will tell you that the more cases that I'm doing side-by-side implants, even with elegant designs that control bone, even with good surgical technique, even growing bone back to the most robust I possibly can, the outcomes are rarely good. And when I look at this, here you're looking at delivery of provisionals post-integration, and you see I'm going to start the sculpting process for my soft tissues. I have some major soft tissue deficiencies that I'm going to be dealing with. And in reality, what we have to do is, from a surgical standpoint, we have to accept that there are still limitations to what we can do with soft tissues. And a lot of the time, I would tell you, I still have to rely on what my restoring colleague can do from the aesthetic perspective in masking the deficiencies that I've not been able to recapture. So here we've rebuilt the deficient soft tissues with pink ceramics, and with a reasonable result, especially with a natural smiling distance, but it's not my gold standard or what I aim to produce. But the reality is that I think when we look at the limitations of papilla, I constantly remind myself to treatment plan before I treat, because every once in a while we get very eager to get in there and just get going with the treatment, but you got to sort of sit back once in a while and think about what will the outcome be and what could I do different to make it better. So when I was sent this case, I was sent the case to remove the central incisor and the lateral incisor. The central has a very deep oblique fracture, and you can see clearly the horizontal fracture on the lateral incisor. And then I kind of sat there and I looked and I said, okay, I know what I'm going to be challenged with that tissue architecture. So I remind himself to think about what have I read about, what have I heard, what have I seen people present. And really, it reminded me to think about the concept of avoiding the side-by-side implant if I can. And it reminds me to think about things like root banking or preserving the ridge through the value of what those roots can sometimes do for me. So what I chose to do is I extracted the central incisor, which we felt was not manageable with crown lengthening or any other treatment, and we submerged the root. You'll see that in this case, I've actually submerged the root and had an endodontic procedure done. That was done because the tooth was already symptomatic. Had it been asymptomatic, a vital root submergence would have made a lot of sense. But what did I do to maintain the tissue architecture in the central incisor and over that submerged root? I did a ridge preservation procedure. I've done a soft tissue augmentation procedure to help bury the root and to further improve the biotype. And I've transitioned my patient with an Esthetics splint, which sort of held the soft tissue architecture for me. Now, my key then, from a surgical standpoint, is I have to think about what this does for my restoring colleague at the end. And that means that I really have to think about restoratively driven implant placement, put the implant in a position where we can think about a screw-retained restoration for the purpose of retrieval should we need to reaccess that lateral incisor which has been submerged. So carefully using a surgical guide, place an implant. I'm using an implant which has excellent primary stability. I'm looking for implants that give me super soft tissue, hard tissue stability at crest. Those are my keys today. And then I ultimately move on to transitioning the patient and developing tissue architecture with the provisional restoration. So I went through my integration, and here I'm delivering the provisional at about 10 weeks of healing. And you can see that we're seeing some fairly nice semblance of tissue architecture. I don't think it's perfect, and certainly the papilla is not symmetric with the contralateral side, but it's a very reasonable treatment outcome. So now I have set myself up for stable tissues long term. I gave my restoring colleagues something to work with where I felt they have the option of retrieving a restoration, the definitive restoration, but this is where communication is so important, and sometimes it fails. As much as we think we talk well amongst ourselves, sometimes we don't. So in fact, when I take you to look at the radiographs over time, if you look all the way on the right side, what happened? Well, this is a cemented restoration, definitive restoration. It's not a screw-retained one, so somehow there was a failure to transmit the message that there's value to screw retention for purpose of potential retrieval, and the ever so common problem of the incompletely seated restoration. I mean, the more I look and read journals and so on, this is something that plagues us when it comes to cement-retained restorations. Now, what's the problem for us? This is a nidus for bacteria. This is a problem that sets us up for peri-implant mucositis and in some situations peri-implantitis. So it's something we want to avoid. But this is basically a redo at this point in time. So, we can have a vision as to where we want to end up, but this stresses the importance. If you don't do it all yourself, it really stresses the importance of how we communicate amongst the team members. So I try to set bone up to the best levels possible, and I'm very aware that sometimes it demands a lot on the restoring colleagues' end to compensate for tissue deficiencies that are defined basically by those bone levels. Well, today, more and more, I'm trying to take control over bone and soft tissues by thinking about my protocols that I'm using as well. Because this is no longer the generation where we extract, we let things heal. This is a generation where a lot of us are looking at immediacy of treatment, whether it's surgery or whether it's also the restorative treatment. I happen to do a lot of immediate placement, and I do a lot of immediate restoration in my practice. I'm not going to tell you to do every case. Obviously, you have to pick and choose the right cases for it. But if you look at what your literature tells it tells you all these titles, basically under the green bar. Those are great qualities for potential immediate treatment cases. Lots of tissue, robust tissue, low scallop of the tissue, square-shaped teeth, reasonable patient, low lip line. Those are great features. We also know that our literature tells us that these are the risks. So you've got somebody who's highly scalloped, you have very, very demanding, aesthetically demanding patient, high lip line. They have a triangular shaped shaped teeth. These are the don'ts. They'll tell you don't think about immediate placement and restoration in these cases. They are risky. But I'm going to tell you that I completely disagree today. Other than in that little black box, which to me means I have no bone in which I can go and anchor my implant, I am absolutely going to look at, can I do immediate placement in these cases? Because when you have a thin scallop, if you do not get something in there, when you have the most bone available, I guarantee you, you're going to come back and treat that case and you will have changes that have occurred in that tissue that we can't always recapture. So I look at these to me are the musts. If I can, I want to think about immediate protocols. I have lots of literature today to support these concepts. We know that these protocols are as effective and as successful as delayed placement and delayed restoration protocols. The reality is they're demanding procedures, though. All of us, when we get involved in more involved treatment, it puts a lot of pressure on us. There's a lot of demands in terms of the fineness of our work, the precision of our work, the communication amongst the team members. So when I think about immediate placement, I want to take you through a few cases to show you what's possible and to maybe challenge your thoughts here and there. This, to me, when I look at the clinical, it's a great case. Nice, robust tissues, periodontally healthy patient. Radiographically, I've got good palatal bone, good apical bone in which to engage my implant. This is an excellent case for immediate implant placement. So my charge is now to carefully extract a tooth, use a variety of different instruments and tools that let me elegantly remove teeth without damaging hard and soft tissues. I then want to place an implant in a restoratively driven position, which means I'm going to use some kind of surgical guide to help me position the implant in the best position possible. I'm going to use implants only that give me high primary stability, that give me excellent crustal bone stability, that give me good soft tissue stability today. And I'm going to think about how do I manage bone in these cases. Every time you extract a tooth in an immediate protocol where you're placing that implant, you're going to have some kind of residual defect. And those residual defects really have to be treated today. You know, we all reference Grunder's work, which said you need at least 2 millimeters thick bone, 3D around your implant. But today, our literature is perhaps making us think a little bit out of the box, and in fact, that we probably need a lot more bone when it comes to immediate implant placement at the time of tooth extraction. So when I'm doing an immediate protocol, my goal is now I'm aiming for at least 4 millimeters of facial bone and soft tissue volume to ensure long-term soft tissue success. And when I'm grafting those areas, I'm very deliberate about what products I'm using. If you look at this article, although it's quite a few years ago, what they looked at was the effect of using an anorganic bone graft material, and that was the product BioOs in the residual defect. It's a structurally stable product, and we know that it's biologically integrated, but its role is really to help compensate for the fact that our very thin cortical bone plate on the facial is destined to resorb, even if we've done this in an incisionless technique. So in an immediate protocol, I very carefully think about size of implant. Obviously, you have to think carefully about 3D positioning. And that residual defect, that's my ally. And my goal is to aim for lots of room, robust hard tissue that we're going to reconstruct there. And my goal is to think about structurally stable products. Whereas, a lot of people will tell you autogenous bone is still the gold standard. I tell you, I think I question that in the residual horizontal defect because I really am looking for something that I know will stay there long term, something that is truly structurally stable. I want to compensate for the fact that the facial bone plate wants to resorb. So this is post-treatment. Now, my goal is to also, if I can, provisionalize my patient. In provisionalizing, whether it's one or multiple restorations we're placing, I'm looking very carefully at contours. So I may have taken a fixture-level impression, sent it off to the lab, or I may have fabricated something chair-side. But I have to look very carefully at the subgingival contours and create an environment where I can allow a robustness of the soft tissues, right? Because I think what we don't emphasize a lot is, we talk about how good bone is for long-term stability of tissues, but thick, solid, soft tissues, in fact, are equally important to the tissue staying stable over time. It's kind of like, although I'm not talking about today, I look at platform switching. Everybody talks about bone. Well, to me, platform switching, its huge benefit is it leaves me room to make lots of soft tissues, and thick, robust tissues are my key to long-term success. So when we provisionalize, here we're looking at several months later, my role or my goal in provisionalizing is, sure, it's making a happy patient because they've walked out with a tooth, but my goal is support the tissue architecture, define the papilla, keep it captured at the level where it came in when the patient was losing that tooth. And again, more and more of our literature validates that we're able to create very stable and good treatment outcomes, even as I start to move into less favorable biotypes. So this is almost falling into the realm of, what our literature says is getting risky. A little more triangular shaped tooth and a little thinner biotype. But radiographically, we knew that there was good bone volume to extract and place the implant. I have a patient who's cooperative and I think will control their function in this area. My goal is correct 3D placement, manage the residual defect, enhance the gingival biotype, and for those of us who are more surgically oriented, we have to all of a sudden start thinking like dentists again and realize, okay, I have to be aware of where those contact points are. I have to allow the impetus or the guidelines for the soft tissue to creep back into those areas. And I've done a connective tissue graft here to enhance the gingival biotype, and we've done it in a more clean, more microsurgical way. Now, I thought I did this procedure really carefully and beautifully, and I'll tell you, the early healing tissues were perfect. And I looked at these photographs post-definitive restoration, and this is with the lip line. And although it's nitpicking, because it is a small defect, but it is a defect. And when you look at this, you can see that the papilla is slightly blunted. And I'm going back and looking at my cases, and if I'm going to be deficient of papilla, and I'm really still not sure why, I'm trying to figure this out, but I see every once in a while post-restoration that we're going to have a subtle deficiency, really much more towards the distal of my restorations rather than the mesial. Now, my contention, though, is that as this matures and over time, technically it should come back, because I'm looking at, well, let's take a look at bone levels, and really bone on our adjacent teeth is really what we know defines our soft tissue level. So if my bone levels are perfect, I would expect that over time this papilla will continue to remature and should come back. But it is one of the little struggles where even with the best of intentions and the best of techniques, we'll still have problems periodically. So surgical protocols, I think, really do influence the hard and soft tissues. Now, that lovely shape, to me reminds me that we body build, we sculpt bodies. Well, as a periodontist, I've always built up soft tissues as well, and gum grafting has been a mainstay in my career. Whether it's teeth or implants, I'm trying to accumulate volume, basically. Now, I've learned probably the hard way, because this is a very old case for me now, and it came back many years later with this problem. And I remember having the clear conversation with the patient at the time that, side-by-side implant placement is going to challenge us. Your papilla is not going to be perfect. And at the time, we were still using titanium in a transmucosal area. So when you look at this is really an ugly end result. Very forgiving lip line, but big blunted papilla, graying through the abutments, shine through, and recession. So what do I think I could have avoided? I think I could have avoided some of the recession at the time had I built tissue augmentation into this case. Tissue augmentation in a variety of techniques, we're all doing grafting of some sort today in our practices. Well, gum grafting is a big part of my practice. And I would tell you I still work a lot with autogenous tissues. I'll still use the patient's tissue from the palate, or if it's a small site, I'll go to the tuberosity. But certainly we know that there's alternatives, and dermal grafts play a big part of what we do today. But my key is here we're nicely taking a really good quality connective tissue, nice clean photographs. Worst thing for surgery is dry like this, right? So when we're working, I'm hydrating, I'm really irrigating to keep things lubricated to enhance how my patients heal. what I'm doing in palates today, because what does every patient say when they come in? I tell them I'm going to take a connective tissue graft in their palate. They look at me horrified, thinking, there's no way you're going to do that to me, because they think it's going to hurt. And we can position it and tell them it's going to hurt, but we're trying to do everything we can to make it a more positive experience where we feel that this is the right technique. So clean microsurgical techniques, doing things like building in autogenous growth factors or PRF might help. I'm not convinced it's the end-all and be-all, but I do see a little bit of pain reduction in the patients where I've actually used it. I'm trying to think about how I close, and I go back and forth with playing with different suturing styles, different materials, because I really do think that different sutures will have different outcomes for us. I'm using glue bandages, basically. I'm using adhesives, which literally protect the area as well. And my goal is to see this kind of healing. But I'm going to tell you that I don't always. This is very early into the healing process, but I'm going to get some patients that come in and very slow healing. And in fact, you're going to see much more of a cave or a cavern, and tissues have to regenerate. Everybody is a little different in terms of how they heal. But our goal is get great tissue quality. So when you look at these grafts, this is excellent fibrous connective tissue. That's going to produce a great graft no matter where I put it. If it's around teeth, around implants, it doesn't matter. When I'm using these kind of tissues around implants, I have an implant as an ally to help hold it in position. So I kind of do a lot of 3D grafting today around my implants. So I graft around healing abutments, and it helps hold my graft in position. I don't always elevate a flap. I'll actually often tunnel and just literally stuff it in there, basically. I'll graft around my provisional restorations. And what I'm finding by doing that is a lot of the time, getting a bit of a more robust volume on the palatal and interproximal gives me a better aesthetic outcome. So it helps to stabilize it, but a better aesthetic outcome. Although because I unfortunately didn't take longer photographs on this individual, what this photograph shows you is two very differing qualities of graft around these two healing abutments. And the more I look at my receding gum cases around teeth or implants, the more I'm convinced that we better be looking at quality of tissues that we're placing in there, because the more fatty, the less stable things will be along over time, the more inflamed it will be in the initial healing as well. So I'm always analyzing when I'm taking a graft, what's the quality of this graft, and do I feel it will remain stable over time? So it's one of the reasons why I also started exploring several years ago working with dermal grafts. And this is one form of a dermal graft, same technique, all around my healing abutments, used to augment the soft tissue volume, to protect bone, to improve the tissue characteristics. And I was starting to convince myself, I think, that one product was better than another, but I keep my mind open and I go back and I experiment. I do lots of split mouth designs. Half the mouth gets this on that side and something on the other side. And we have a lot of different dermal grafts available with many unique features. But the more I do this, the less I'm convinced that there's one that's superior to another. So it's almost like we have to learn to work what works best in each individual's hands. But there are a lot of alternatives which are valuable alternatives to using autogenous bone if appropriate. Now, I put this slide in because I have been for the last 10 years talking about the important role of the gingival biotype in implant therapy. I have been totally convinced that you have to graft in a lot of your implant cases for soft tissue stability. But then I start, every once in a while you get stuck in your ways and you have to start thinking out of the box. You listen to other people, you talk about cases, you read literature. And you want to know how confusing the whole picture is, you start looking at literature. And I took some literature from one group, and I want to show you how over time their own thoughts evolve. This is an Australian group, and what they initially said in 2007 was that there's no impact or relationship between the biotype and post-treatment recession, because in fact that's what we're trying to do. We're trying to stop post-treatment recession. Come along 2008, they've said there's a slight relationship between the biotype and post-treatment recession. 2009 is that, yes, it's starting to show to be an important factor. And in fact, in one of their more recent studies, they said that, well, where they didn't graft, they had more poor results compared to the sides that they actually grafted. So again, whether it's our patient populations, whether it's our techniques, it puts into question how essential is grafting in our treatment protocols. So there are times where I think a thin gingival biotype is not a problem. In this case, this is obviously a reasonably high scallop, very thin biotype, but what's the advantage is I have a lot of bone underneath there. It's a robust bone because of the root resorption here. And so maybe bone is going to afford me the opportunity to not think about augmentation because, you know, the big problem with augmenting soft tissue, as elegant as I think I might be able to do it, you can always tell there's been a gum graft done. It always looks a little different. The most beautiful tissues, I feel, are truly those thin biotype cases. So what did I do here is I extracted the tooth, and I reminded myself that, wow, for a change, I've got a tooth that I can work with. Let's look at the value of this tooth in terms of what I can do in contour generation of the soft tissues. So I took the facial aspect of the tooth, hollowed out the whole palatal, and I indexed it to a transitional abutment and indexed that intraorally. And then I finished it with composite, and I'm going through my polishing and my cleaning process outside of the mouth. Now, this is basically taking you on day of surgery, where you see my implant position, the non-opaque peak abutment, seeing the palatal and the facial view. And again, even though this was flapless surgery, just literally putting an implant in post-extraction, you see what happens to papilla the minute we extract a tooth. The papilla blunts, right? So it's more flattened. But if I have thought about the contours of that tooth facially, interproximally, think about where the contact areas, I've given incentive for those tissues to come back. So here, looking 8 weeks later, you can see very nicely how the tissues have recaptured themselves. To me, I listed these points because I think these are the most important features to the stability of my soft tissues. It's very carefully think about size of implant. You know, it's not always bigger is better. Something smaller is sometimes better. Think about maintaining bone volume, and that's what thinking about size of implant allows me to do. And the more microsurgical we can be, the more minimally invasive, the less cutting, the better it is for your tissues. And idealizing implant position, obviously, but thinking restoratively, where do those contacts go? How does that define my tissue architecture? And so sometimes I put the comment that maybe the biotype is not critical. If I have all of those other features that are right along the way, I can truly control the soft tissue architecture. So it sort of gives you an idea that, you know, yes, on the surgical realm, whether a periodontist, an oral surgeon, a lot of us are realizing we have to provisionalize because it does a lot of great things for the soft tissue architecture. But provisionalization, you know, I mean, it's the most painstaking part of the surgery, I find. I mean, to me at this point, you know, the placement of the implant and all the hard and soft tissue management is the simple step. And now it's really look at what defines the fineness and the characteristics that I need in terms of papilla development. I think that where I can build in fixed restorations at time of surgery is where I'm going to get the best results possible. So fixed is where I go. But the reality is we know that we have to transition patients with a variety of techniques, depending on implant stability, depending on the number of implants, depending on patient cooperation and habits. I'll go anywhere from removable prostheses to fixed prostheses delivered on day of surgery. The goal of, you know, provisionalizing, whether it's one or multiple implants, is perfection of the tissue architecture. So if you go from day of insertion or day of surgery through to post-definitive restoration, it's really making things seamless. Yes, your patients drive the decision to think about fixed provisionalization where possible. But for me, the clinician, the fixed provisionalization lets me perfect tissue architecture. In this example, I think really nicely contrasts the problem of the healing abutment versus the transmucosal temporary restoration. You've got perfection of tissue architecture, so if you have to transfer this information to your technician, you've given a great picture of what your vision is for the subgingival prosthetic envelope. Whereas a healing abutment, you gave them a little hole, and certainly you hope that you're not going through to definitive restoration at that point in time. Now, yes, sometimes I place healing abutments, like I can't always deliver some kind of fixed restoration. And healing abutments in themselves can really influence tissue healing. So whether it's the shape, the size, how you handle them, what kind of surface treatments there are, these all impact the soft tissue volume and the soft tissue stability. So when you talk about tweaking the system, all along the way, we can do little things that accumulate to produce a better outcome. So on a healing abutment, I might do something as simple as I'm going to use a chlorhexidine gel, a 1% chlorhexidine gel to reduce the bacterial reservoir. I'm going to do the same with my transitional or provisional restorations as well. I'm thinking about if I'm placing a healing abutment, I want to think about how am I placing it. Today, absolutely, I'm going to torque those in place. I'm not going to finger tighten them because that's going to be a dirty area. And in fact, we know some of our supporting literature is suggesting that you have to have at least a 20 Newton centimeter insertion torque for your healing abutments to reduce bacterial penetration in those areas. But where I can't provisionalize, so let's say my stability on my implant's not enough, or I'm worried about my patient's parafunctional activities. I don't want to finish a surgery today with a healing abutment that looks like that, because I know what's going to happen to that papilla. It's going to slump, and then you're going to have to go through a redevelopment process. So what do? Is not this anymore because of the collapse of the tissue architecture. Today, and I think we have a lot of great opportunities with digital technologies that are coming out, but today I'm routinely creating customized abutments. Most of the time I'm doing them at this point in my career intraorally, but I think there's all sorts of avenues that this can create it. So I don't have a tooth in place, but I have the subgingival envelope scaffolded and supported. And when I looked at this, I started seeing some great treatment outcomes, and I started exploring this. So this is taking you through understanding the value of defining the tissue, or actually not defining it, but supporting what I was given to begin with when I extracted that tooth. Here I'm principally supporting it with the healing abutment, but I'm thinking about when I'm using a transitional splint to also use it to my advantage to scaffold and support the tissue architecture. So post-extraction, first thing I look at is that papilla is slumping into the extraction site. So I take some kind of transitional temporary abutment, whether it's a titanium or a PEEK style material. I customize it intraorally with a composite material. Here I'm tunneling a graft onto the facial, and my goal is simply don't lose the tissue architecture. Maintain its contour. So when you revisit the typical case, looking at this is about 3 months after surgery, taking out the patient's removable prosthesis, we have a well-defined tissue architecture. You take that out, and this is what I want to see the restoring dentist transfer to the technician. That is a defined tissue architecture. At first, I was going from my custom healing abutments to a provisional restoration, and I started looking at that. I said, it makes no sense. It's a step that, in fact, we can skip today. So I took off my custom abutment or healing abutment, and we're doing the final restoration here, customizing an impression coping, and literally going right to final restoration. In our practice, that would have been taboo in the past because I'm so strongly opinionated about the fact that you have to have perfectly defined tissues to perfectly define where you want to see your cement line if you happen to have a cement retained restoration. So here you can see the zirconia abutment's been designed with the mind of where do I want that margin to be and go on to definitive restoration. It sets the tone for, I'm setting this tone through this little step for my restoring dentist to have success in the definitive restorative plan. Now, a lot of the time, periodontists don't often look at abutments or definitive abutments, but I realize that I better understand these well because they have a big impact on my treatment outcomes. And we are obviously in the realm where we're looking at the most biocompatible materials in that transmucosal area that to do some great things for tissue stability and tissue aesthetics. Today, you're in the zirconia era. Obviously, there's also Emax and other materials, but you have materials that are strong, that are very resistant to fracture. You have materials where you can bring them into functional areas and reduce the risk of ceramic fracturing or chipping problems. I think about the benefits of zirconia from the biocompatibility perspective. This is a great material. It's even more biocompatible as we know it than titanium. Bacteria just doesn't like it as much as it likes titanium. It's a great material to have coming through that transmucosal area. But biocompatibility is only as good as how we let it be handled. And in fact, we can do a lot of bad things to zirconia along the way to make it less biocompatible. So when you look at as-milled zirconia, you can see all this little hatching. This is its most biocompatible state. The minute our technicians polish that out and get, grit stuck in there and so on, you're reducing the potential for soft tissues to nicely stay adherent or happy about having that in the subgingival area. So we think about how we're handling it. And we also today, and unfortunately this has come through learning through problems, we started looking at that abutment design here, which is routine in our practice for so many years, and we're looking at the little gray areas on the head of the implant. We realized that that's titanium wearing off from the inner part of the implant to the head of the implant on the zirconia abutment, and wasn't so worried about that until eventually we started looking at problems that were occurring, and that is abutment fracturing. And where are abutments fracturing now, years later? So usually we're at about the 2-year post-load is where we see the problems occurring. We're starting to see abutment fractures. Now, I also want to tell you that we avoid today by thinking about what's going in the head of our implant. But as careful and as fastidious as we are about the cementation protocol, I put this little arrow there to show you that we thought we got all the cement out. We thought our hygienist was maintaining effectively, but there's still cement. So what do I deal with as a periodontist is I get implants sent into me with problems, peri-implant mucositis and peri-implantitis, and I know Glenn's going to be talking about that. It's a big problem today, and I am convinced, although it's multifactorial, I'm convinced that this is one of the big issues, is cement trapping. So today, when we're working with our transmucosal materials, we're looking for abutments that are aesthetic, whether they be lithium disilicate or zirconia, but on a metal base. And there are interesting metal bases. This one happens to have a laser lock on there, which we think might be of value to us in the long run in terms of soft tissue health. And we're thinking about our cement lines. We're doing everything we can to enhance health and maintain aesthetics. But what you consider deep as a cement line, or what I did until I started reading this article, is even going 1 millimeter subgingival with your cement line, it is a problem. Your risk of cement entrapment in the subgingival area dramatically goes up. Our ability to detect it is poor. Obviously, our radiographic ability to detect it is poor, especially if it's facial and palatal, but depending on the thickness, it is a problem for us. So when we design abutments, they are almost equigingival today. The cement line is in the most accessible position possible in order to reduce the biologic consequences of trapping. It allows the restoring dentist to think about the abutment the same way as they deal with teeth, right? You don't want margins buried miles underneath tissue. You want them in accessible areas. Well, as a periodontist, it also forces me as much as I can today to think about, can I avoid cementation? Can I think about screw retention? But what I thought was screw retained is not always screw retained, because in the 2 cases where I show you with a little box there, the problem there is the ceramics cannot characterize the ceramics in that area because I'm too close to the incisal edge. So it forces me to be much more careful in my treatment planning and where I'm actually putting my implants. So what I've had the opportunity to do with you today is to spend a little bit of time to tell you that, you got a treatment plan before you treat. There's a lot of very interesting things that we can do with bone and soft tissues, whether it's autogenous or a biologic. There's a lot of interesting implant placement and restoration strategies, and if I can think about immediacy, I do. I think it's a great thing in terms of what it does for soft tissues and the outcome. And we always aim for the best, all of us do, right? You want to do your best possible, and we aim for it, because we know sometimes it's not going to work out as well as we want, but we always want to try to achieve the best with our patients. So I hope you have a wonderful 2 days of education, have lots of talks and over a glass of wine, a beer, etc. Learn a lot. And I appreciate the opportunity to have spent some time with you today. It's been a great adventure for me, and thanks to David and the Salamas and all the hard working AVT behind you. Thanks. Thank you.